So let's assist Jen. Jen says she does not understand she didn't understand that particular point. Jen, not all diabetes is diabetes mellitus. There are two types of diabetes. We have diabetes mellitus, and then we have diabetes insipidus. Who has understood the way I drew up a difference between the two? Who can attempt? Unmute and give your submission. What is the difference between diabetes mellitus and diabetes insipidus?
Thank you very much. For diabetes mellitus, it deals with the inability of the body to deal with the excess glucose levels. I'm trying to be brief so that maybe someone can get clear. Then for diabetes insipidus, it deals with malfunction on how water regulation is being managed, where someone loses a lot of water compared to the normal state. And they're all metabolic disorders.
Okay, thank you very much, Derek. You have been quite simplistic. Let me see. Paul is asking, his network is not stable. To repeat. Okay. Okay, I think Robert was making a submission to the question. So just to add on what Derek had said and articulate some few facts. Diabetes mellitus is what we are talking about today. It is a chronic non-communicable disease whereby the patient presents with a cocktail, a group of symptoms and signs characterized by chronic hypoglycemia that result from a defect or an abnormality in insulin secretion or the way insulin exerts its action. So when we say that, and we shall get to that in a bit, and we shall say that when we say that a defect in insulin production, we are saying you are most probably producing a little or no insulin. In insulin action, we are commonly referring to insulin resistance. But I also want to assure you that we have patients in whom both pathophysiologies play a role. A patient starts with insulin resistance, and as a result, the amount of insulin being produced later on decreases. So you'll find in the definition, they say it is either due to decreased or no insulin, comma, increased insulin resistance, or both. The both is classical for type 2. Someone has obesity and all these other things happen that culminate into a decrease in insulin production. And that's why you see, ladies and gentlemen, we can have a patient whose classical criteria make type 2 diabetes mellitus diagnosis, but then the patient is on insulin permanently. How possible is it? We shall talk about pathophysiology in a bit. Now, diabetes insipidus, on the other hand, is where we have abnormalities in extracellular fluid volume regulation as a result of either a decrease in the amount of antidiuretic hormone being produced, or resistance or insensitivity of the receptors of antidiuretic hormone. Antidiuretic hormone is produced by which gland? Let me ask some few people here. Eston, which gland produces antidiuretic hormone? Eston is absent. Derek, mark Eston absent. Let's continue. Esther Nansubuga, which gland produces antidiuretic hormone? Derek, are you there?
Yes, good morning, sir.
Yes, I'm there.
Yes, Esther.
Yes, sir, I'm not sure of that gland.
Did you do anatomy and physiology in
Adrenal gland.
Yeah.
Let me first ask Esther. Esther, did you do anatomy and physiology?
Yes, I did.
What did you think? You thought we shall not use the material.
I knew it's a gland that is located or above the kidneys, but the name had disappeared.
No, you're actually wrong. No. Esther, Even the one
Yes,
who gave
sir.
the answer, even the one who gave the answer gave a wrong answer. That's why I usually prefer that I select you and you answer before you give wrong answers. Even the one who gave the adrenal gland, it's the wrong answer. So let me ask someone else. Stuart, why don't you assist the class?
Yes, sir. No.
Okay, pituitary gland.
Okay. So Stuart, pituitary gland, I would give you 0 because you're talking like a villager. Stella, mute. Lydia, mute. Stella and Lydia, mute. We have a culture. Stella and Lydia, mute. We have a culture by which we operate here. So if you had Stuart's response, I've given Stuart 0. I have seen Robert. Robert, come back and tell us which gland produces antidiuretic hormone. Hey, you guys are doing badly off. Because you're going to practice public health, you think you shouldn't know these things. And yet they were taught. What do you think they are put in the curriculum? Robert, look here. Robert, where are you? Immaculate Alupo?
Yes, sir, I'm around.
Yes, look here, give the answer very fast. You help.
Yes, I was saying the ADH hormone is produced by the anterior pituitary gland, which acts through the influence of the hypothalamus, which triggers.
Robert,
Yes.
Wrong, not correct. That answer is not correct. Let me hear from Immaculate. Immaculate Alupo, what produces antidiuretic hormone?
The posterior pituitary gland.
Excellent. So the winner for today's academic medal is Immaculate Alupo, who has saved the whole class. She has been your Jesus today. Hey, you guys, this material is taught because that one day you will need it. And here we are. Because now you cannot say, hey, Mugambe set a question on which gland produces, and it is not in non-communicable. The module is called introduction, meaning it should have everything that gives you a broad base on understanding the principles and practice within non-communicable disease, meaning we are going to make reference to this material all the time. So antidiuretic hormone, like Immaculate has told us, is produced by the posterior pituitary gland. The posterior pituitary gland is also known as the neurohypophysis. In this particular case, hypophysis is the other name for pituitary gland. Neuro tells you which histology or which cells make up this posterior pituitary gland. So neurohypophysis or posterior pituitary gland. The other important thing for us to appreciate is apart, Robert, let's mute. Apart from the function, the principal function, obviously, of the antidiuretic hormone is to regulate extracellular fluid volume. And it usually comes in place when we are depleting circulating volume. What do I mean? If your fluid volume, total fluid volume in the body is increasing, what the posterior pituitary gland does is that it detects the osmolarity and the osmotic pressure exerted by the fluid against small receptors found in the hypothalamus. What are we trying to say? We are trying to say that the hypothalamus in this particular case, like Robert was trying to allude to this particular concept, the hypothalamus is the one that regulates the production of hormones by the pituitary gland. In particular, anatomy and physiology tells us that the posterior pituitary gland does not directly participate in synthesis of the hormones that it is responsible for, but rather it plays a role in release. So where are the hormones of the posterior pituitary gland produced from? The hormones of the posterior pituitary gland are produced from the hypothalamus, and they are stored within the posterior pituitary gland itself, and then it will release them. So it means that for the posterior pituitary gland to produce these particular hormones, it will be the one detecting. It will be the one detecting. But since we are saying that for its job is secreting them or releasing them, the one who produces is the one who will detect. Therefore, if someone asks you lightly, where do we find the receptors that play a role in stimulating secretion of antidiuretic hormone following detection of osmotic pressure. We find those receptors in the hypothalamus, and we refer to those receptors as osmo receptors. So the hypothalamus has osmo receptors that keep on detecting the state of extracellular fluid. And in response to the changes within extracellular fluid, they can increase or decrease the amount of antidiuretic hormone being produced. Let me quickly ask Stuart again. Stuart, where do we find receptors of antidiuretic hormone? Antidiuretic hormone has been produced. It wants to exert its effect to protect the patient from developing diabetes insipidus. Where will it bind?
Hold on.
Stuart?
I'm not sure. Yes, please. I'm
Stuart?
not so sure. Yes, please.
I want to assist you to help you generate an answer.
Yes, sir.
You listen to the name of the hormone and decide which organ it operates on. The name of the hormone is antidiuretic
The kidneys.
hormone. Yes, that is it. So the receptors, like Stuart has told us, the receptors of antidiuretic hormone are on the nephron. I'm not going to go into the details because it's not what we are discussing. We are trying to differentiate diabetes mellitus. Why is it important for us to differentiate? We are going to later on discover that insipidus and mellitus share something in common, and that is the polyuria. So each time patients come in with polyuria, with the single exception of maybe being on diuretic therapy, you would need to establish if what you're dealing with is diabetes insipidus or diabetes mellitus. And that's how we arrived at what we are talking about right now. Diuretic hormone, ladies and gentlemen, is simply to detect changes in ECF and respond. Its major outcome is sustaining or maintaining extracellular fluid volume. How does it do it? From the name alone, antidiuretic hormone. It means it exerts its effect on the kidney, on the nephron. The nephron is the functional unit of the kidney, and it stops or decreases urine formation. Diuresis is loss of water through urine. Diuresis. And that's why we call the drugs that increase urine formation or loss of water from the body through urine. That's why we use the name diuretics to refer to that class of drugs. Now, it is important for us to remember that antidiuretic hormone doesn't only exert that effect. Antidiuretic hormone in large amounts can also bind on its receptors on the blood vessels. And as a result, antidiuretic hormone has another name that reflects its other function. What is that? What is the other name of antidiuretic hormone that denotes its second function, apart from the antidiuretic function? Anyone?
Vasopressin.
That is Mohavura. Victoria, thank you very much. So the other function of antidiuretic hormone is to constrict blood vessels. Ladies and gentlemen, you'll understand from the things we are mentioning that the outcome can only be one. The outcome can only be a decrease in the amount of urine that is being formed, so that will retain more fluid in the body. For example, vasoconstriction will reduce. What we constrict? We mainly constrict the renal artery. If you constrict the renal artery, automatically the amount of blood going through the renal artery will decrease. Subsequently, the amount of blood going through the afferent arteriole will decrease. And as a result, the amount of blood going through the capillary network referred to as the glomerulus will also decrease. Meaning that if you bring a little blood to the glomerulus, you're going to decrease on the glomerular filtration rate. And if urine will decrease. Class, am I making sense? Are we following?
Yes, we are.
So it is imperative for us to appreciate that as much as all these conditions meet some form of criteria fall in diabetes because they have hypoglycemia, the two conditions are not the same. So if someone has diabetes insipidus, there are certain things we need to appreciate. For example, we have said diabetes insipidus can be caused by the hypothalamus producing little or less amounts of antidiuretic hormone. As a result, the antidiuretic hormone available is insufficient to sustain the fluid, the sodium and fluid retention to preserve fluid volume. And as a result, you lose. The other second type, and that type of diabetes insipidus I'm talking about is called the central diabetes insipidus. Central diabetes insipidus. Central diabetes insipidus originates from the hypothalamus producing less amounts of antidiuretic hormone. The second type, we have said the resistance or insensitivity. Actually, the best word is insensitivity. The hypothalamus produces enough ADH, but the receptors of ADH on the nephron are insensitive to the ADH that has been produced. So this is what is unique. When you're assessing the patient will be having gross sodium and water loss in urine, but when you sample serum levels of ADH, the levels of ADH will actually be outside the normal reference ranges. The patient will be having sufficient or high amounts of ADH, but then you'll still be losing sodium and water in urine. So that type of diabetes insipidus is what we call the nephrogenic diabetes insipidus. So we have a central diabetes insipidus and the nephrogenic diabetes insipidus. We have said the two conditions, diabetes mellitus and insipidus, share one unique characteristic, and that is in both patients is polyuria. But like we shall see in diabetes mellitus, the cause of polyuria is different. The one of diabetes insipidus we have seen, you are producing little ADH, or the enough ADH you're producing is the nephron receptors are not sensitive to it. As a result, you're going to produce a lot of urine. I want to move on and we talk about diabetes insipidus now that we have drawn the difference between the two conditions. So we are saying that diabetes mellitus is chronic hypoglycemia that results from either little or no insulin being produced, insulin resistance, or both. And we have said there is a unique type of DM that presents with those two characteristics. In which type of DM have we said that the patient has both little amounts of insulin being produced and insulin resistance? Who still remembers?
Pardon the question.
You see, we are talking about what causes the pathophysiology in diabetes mellitus. And we are saying this chronic hyperglycemia can be as a result of little or no insulin, comma, increased insulin resistance, comma, or both. And I gave you the type of DM that presents with both pathological approaches. Which one is that? Keeping in mind.
Sir, it's type 1. It's
now
type
we have
1.
type 1. We have type 1. We have type 2.
Type 2.
Let's talk to Stella, whose hand is up. Yes, Stella. Stella is going to be our tiebreaker. Stella, are you there? Your hand is up.
I think that is diabetes mellitus.
Nice. Stella, where are you?
That is diabetes mellitus.
Which type?
Sorry?
Okay, Stella, you mute. Stella, mute. Let me ask my friend, the Cotias. Cotias, are you there?
Yes, I'm there. Good morning.
Morning, madam. So if you are listening in, which DM type? Keeping in mind that Jennifer gave us two major types of diabetes mellitus, type 1 and type 2. In which type of DM do we have both insulin resistance increasing and culminating into a decrease in insulin production?
I think type 1.
Okay. The answer is DM type 2. You people, we can't have insulin resistance in DM type 1 because there's no insulin to even resist in the first place. Kotias, am I making sense?
So in type 1, the body is not producing enough insulin.
It is not. No, it is actually not producing any insulin.
Yeah.
Let me use that word. It is not producing any insulin. But you see,
Yeah.
in type 2 diabetes mellitus, the body is producing insulin.
Yes.
But since the classical picture of DM type 2 is obesity, we are going to see in part of physiology how fat in the adipose increases insulin resistance. So this is what, let me just give you a quick picture into how the insulin resistance results into a decrease in the amount of net insulin being produced eventually. So this is what is happening in Cotias. The body has sugar. We have taken a carbohydrate diet. We have taken the carbohydrate diet, and the polysaccharide has been broken down to a disaccharide, which has been broken down to a monosaccharide, and we have our glucose. And using glucose transporters, we have absorbed glucose and taken it into circulation. When glucose enters circulation, the glucose will find its way to the pancreas and will initiate a mechanism called glucose-mediated insulin release. When insulin is produced by the pancreas, this insulin is supposed to improve glucose uptake by certain tissues. Ladies and gentlemen, not all tissues, because like you are told in anatomy and physiology, some tissues take up glucose independent of insulin. So ideally, the guy who taught you physiology should have told you that all glucose uptake is by glucose transporters. But some glucose transporters need insulin for them to exert the glucose uptake effect, others don't need. So each time we talk about insulin, ladies and gentlemen, we are going to strictly concentrate on areas where the glucose transporters need the presence of insulin for them to take up the glucose. So Cotias, this is what is happening. The biggest consumer of glucose is skeletal muscle. Then you talk about the adipose. Then you talk about the liver, where we shall be turning the glucose into glycogen for storage and the likes. So in the areas where insulin is needed for the glucose transporters to exert their effect, for example, in the adipose, the more fat you have deposited there, the more the glucose transporters are obliterated. The insulin receptors, sorry, the more the insulin receptors are obliterated or covered or blocked. So that means that in an individual who is obese, the chances of having many insulin receptors blocked is very high. What is the eventual repercussion of this? The repercussion is glucose was absorbed, glucose-mediated insulin release by the pancreas was activated, the insulin was released into circulation, the insulin went to bind on areas where glucose uptake is mediated by its presence, and it has found its receptors are occupied. So what is the outcome of this? The outcome is the cell will not take up glucose because insulin didn't bind. Remember, we are saying that when insulin binds, then the glucose transporters are expressed on that tissue, and those glucose transporters will cause glucose to be taken up. So if insulin cannot bind to its receptors, the glucose transporters cannot be expressed by that tissue. If the glucose transporters can't be expressed by that tissue can't take up glucose. So all that glucose will put in saturation, causing hyperglycemia. But let me remind you about your positive and negative feedback in anatomy and physiology under homeostasis. If the intention was for glucose to be taken up, and the only way the body detects that glucose has been taken up is by a decrease in glycemia, in blood glucose. When the blood glucose persists at an elevated point, it will automatically again stimulate the glucose-mediated insulin release by the pancreas. It will constantly do it until its intended outcome, which is a reduction in blood glucose, has been achieved. So what does that mean to the pancreas? It means the pancreas is going to overwork. Class, am I making sense?
Very well, sir.
Yes, sir.
It means the pancreas is going to overwork. In the overworking, we shall have degeneration of the cells. Because remember, the cells are supposed to operate and rest. The cells are supposed to operate and rest, but here the cells are constantly being stimulated. The constant stimulation, which is as a result of the insulin resistance that is at the target tissue, is going to cause the pancreas to overwork, and the overworking of the pancreas is going to cause degeneration of itself. What does degeneration mean? Degeneration, one of the classical ways of appreciating degeneration according to endocrine anatomy and physiology, is the amount of hormone being produced by the organ will decrease. So if we said that someone is having a pituitary, a tumor of the anterior pituitary gland, and it is causing disfigurement and degeneration of the pituitary, how can we know? We just need to sample the patient TSH, CRH, growth hormone, they will decrease. Why? The histology, the cells of the tissue itself that is responsible for producing those hormones is being affected. So this is how a patient with a type 2 diabetes mellitus who has insulin resistance can end up with a little amounts of insulin being produced. The little amounts of insulin, ladies and gentlemen, doesn't come at the offset of the condition. No, the little amounts of insulin comes as a result of persistence and the failure of compensatory mechanisms to sustain the patient. That is why you see the NCD policy in Uganda, like we discussed in our inception lecture, its main focus is not on DM type 1, because, ladies and gentlemen, let's agree that there is no prevention you can institute for DM type 1 to stop the condition from developing. Keeping in mind, ladies and gentlemen, that the levels of prevention we agreed upon are primordial, primary, secondary, and tertiary. You cannot stop DM type 1 from developing. It will develop because it is mainly associated with certain certain factors that we do not have that much control over. So DM type 2, where we can be able to anticipate. By the way, I always ask my students, let me ask you guys, in DM type 1 and DM type 2, where do we have a genetic component?
It is type 2.
Excellent. Robert DM is disturbing, I have seen. So it is type 2. Who gave the answer? I don't know these things of just answering.
Esther
Nansubuga, thank you very much. So, and I mentioned this when we were starting, because it usually disturbs students. You find a patient who is 25 years of age with chronic hypoglycemia, and the student is taking history and asking, is there a history of diabetes in your family? It's okay to ask. But what would be the relevance? You're dealing with the juvenile or type 1 type 1 diabetes mellitus. Where do you expect the genetic component to come from? So the genetic component is usually classical for DM type 2, not type 1. But then the gene, remember we agreed, ladies and gentlemen, that this issue of gene, like in hypertension, the issue of the gene is that the genetic inheritance will affect certain physiological processes. Those physiological processes are affected by availing certain environmental conditions that will stimulate the progress of the disease. For example, the modifiable risk factor for DM type 2 is obesity, meaning that if we can institute measures as public health practitioners to ensure that we reduce on the prevalence of obesity, then we shall to a very large extent have managed the occurrence or prevalence of diabetes mellitus type 2 in the community. Am I making sense on the link between the two?
Yes, you are.
Kotias, your hand is up. Yes, please.
Yeah, my hand is up. Thank you very much. This is a very good and easy explanation. I am able to follow it. I have a question. Now we are having issues with especially the young, a lot of obesity in the young kids, maybe from the age of 6, 7 and above. From your practice, have you gotten type 2 DM within such age category? Because when you look around, especially in the urban setting, there are so many kids who are really obese. So I don't know whether it comes at a certain age, or you have observed some of them having even diabetes type 2 at a young age.
Okay, thank you very much. My experience is this. Even if we are to classically, because of the component of, we call it childhood obesity, even if we were to classically approach the childhood obesity as a cause of diabetes mellitus, where I would be defeated from Cotias is on management. I don't know if I'm making sense. For example, you should have noticed that nearly, if not all, childhood obesity related diabetes mellitus, which would now, because of age, fall under the category of type 1 diabetes mellitus. All of it is non-responsive to oral hypoglycemic agent. Maybe someone else can share their experience where they found a 15-year-old with diabetes mellitus and they're taking metformin alone, or glibenclamide alone. Is there anyone who has seen that?
No, on my side, because I think it's a gradual process with the type to like take some good time for. We shall look at maybe the predisposing factors.
So thank you very much. So this is what I'm trying to say, that Cotias, as much as the component of obesity is there, all these people have other underlying, all these children have underlying pathological states that are the ones that eventually result into the diabetes mellitus. So you find that most of the childhood obesity associated diabetes mellitus is type 1. And as a result, you notice that all these guys are taking what? They are taking insulin as their mainstay treatment. However, we shall have a session on childhood obesity. No, I will share with you an article on childhood obesity. It's, I think, a 2019 article. It has very nice information on how the pathophysiology, the epidemiology, determinants and risk factors, differential diagnosis, then prevention, where a public health practitioner can come in, and then pharmacological, the prevention, non-pharmacological treatment, and pharmacological treatment. I should be able to share that before the end of today's session, and you guys look at it. Now, I think we have covered enough of the basic information. Let's quickly dive into the details. Now, we are saying that we can look at the risk factors of diabetes mellitus. What are the risk factors? What would come into your mind? Remember, we said with these non-communicable diseases, there are risk factors. Risk factors. It's very difficult for someone to get up in the morning and they have a cancer. They must be constantly interacting with something that is modifying or changing physiology and inclining it towards abnormality. So as for that diagnosis eventually develop. Anyone? So we are seeing some risk factors in the group. Procy is saying modifiable. Now, Procy, I don't know which question you're answering. So Stuart is saying sedentary lifestyle. Stuart, I entirely agree. I hope by now the class understands what sedentary lifestyle is. Mbabazi is saying obesity. I entirely agree. Let me see. Derek, poor diet. This is a very broad term. What do you mean? I'm seeing also Esther saying diet. You guys need to commit yourself. You need to commit yourself, because poor diet could be undernutrition, poor diet could be overnutrition. So what exactly are you talking about? So I think someone who has said obesity, or someone who has said consuming diet rich in excess saturated fat is one I would want to go with. Eston is saying idleness or inactivity. I would prefer inactivity. Idleness may not be the appropriate English word to describe what we want here. Courteous lifestyle, yes. Procy, finally, you have given the answer I want. So Procy, I have understood that Procy is doing. Procy is trying to approach the risk factors using the format that we agreed. I remember telling you that when you're reading about risk factors for any of the NCDs, I beg you, try to put them in context of which one is modifiable and which one is non-modifiable, because that is what is making noise for us, honestly. He's making noise for us. Guys, you mute. You can't. Okay, so I have lost a bit of track. Lifestyle, yes. Abraham having a history of heart disease. Having a history of heart disease does, excuse me, does not increase the risk of developing diabetes mellitus. It is actually the other way around. Abraham, you remember we said having diabetes mellitus increases the risk of developing hypertension. Sedentary lifestyle, yes. Diet with high levels of carbohydrate, yes. Lack of physical activity, and the like. So we are understanding the concept here. A risk factor is one that will increase the chances of someone acquiring a certain pathology. It does not necessarily mean, ladies and gentlemen, that having a family history of diabetes mellitus in your family, you're going to suffer from diabetes mellitus. No. But we are saying if you had a history of diabetes mellitus in your family, you carry a gene that can manipulate a favorable environment, for example, obesity, and cause you diabetes. I hope you understand. And as a result, we agreed on the approach that Procy has been sharing. You know, initially, Procy, you are sharing these things in an abstract manner, and I was wondering what you're doing. So Procy is using the approach which we agreed on, that as a public health practitioner, when you're thinking about disease, you should think about where you can do something and where you can't. For example, you can't do anything about age. You can't do anything about the genetics, because diabetes mellitus, the genes are not carried in a sex-linked manner. So we do not have the component of saying that, oh, we can apply Mendelian to what? To diabetes mellitus. These genes are not auto-recessive genes. So it does not apply in this particular context. Genetic counseling can't help, like it would help if it were sickle cell disease. So Justin is talking about injury to the pancreas and all those other things. Let's talk about the pancreas itself. I am mentioning this so that we can all come back on board and understand what we are discussing. And here we're going to spend maybe 1 to 5 minutes, and then we shall quickly move on. Now, the histology of the pancreas is in that the pancreas has two major types of cells. The pancreas has acini cells, which constitute what we call an exocrine pancreas. Appeal is asking an age-based risk factor. Class, can age be a risk factor for diabetes?
Yes, it can.
Yes, age can be risk factor. Who was that? Who answered?
Jolly.
Oh, finally, Jolly, you showed up for class. So congratulations. Okay, yes. So age can be risk factor for diabetes mellitus. Jolly, which type of DM would that be? Type 1 or type 2?
Type 2.
Okay, very good. So what Jolly is telling us is totally correct. It is, when we're looking at diabetes mellitus, it is usually like this. The older you get, the higher your risk of developing diabetes mellitus. You'll all agree with me that it is, if we're to look at DM type 2 and type 1, the burden of the two types of DM varies or is totally different. If I were to ask, maybe let me ask, I'll pick Jolly, Jolly and Derek. Let me start with Jolly. Jolly, your experience at your medical center, at your hospital, which of the two cases do you receive the most? DM type 2 or DM type 1?
Type 2.
Excellent. So that would mean that we are at a critical threshold whereby the older you get, the higher the chances of you developing what? The diabetes mellitus. Meaning that if we're to look at an average outpatient clinic, you'll find that you'll be handling more of the proportion of individuals who have DM type 2 than DM type 1. And that is where the age component becomes a risk factor. So you have had things like you should eat or consume food proportional to your age. I don't know if you had such a thing. People usually randomly put it as you should eat your age. And the eating your age comes from the fact that the older you get, the lower the body demands. And as a result, your calorie intake, your fat intake should greatly be reduced and replaced by other things like vegetables, food rich in vitamins and minerals and the likes, as compared to loading the body with the calories as though you were a 10-year-old or 15-year-old male or female. So the issue of you should eat your age, let me see who asked if age was a risk factor. The issue of you should eat your age is clearly telling you, Apio, the issue of you should eat your age is clearly telling you that the older you get, you should decrease on some of these foods, which if consumed in large amounts would increase the risk of developing some of these conditions. So let's go back to the pancreas. The pancreas is a mixed gland. By being a mixed gland, it means that it serves both an exocrine, that is digestive, and endocrine function. So the acini cells, which constitute the biggest part of the pancreas, meaning that the biggest part of the pancreas is dedicated to digestion, not endocrine. So the pancreas is more populated by exocrine cells, acini cells, than the endocrine cells. Now, the general name given to the endocrine cells of the pancreas is the islets of Langerhans. It's important for us to remember that the islets of Langerhans are mainly 3 in type. And this gives rise to the histology of the endocrine pancreas, meaning that we shall say that the endocrine pancreas has beta cells, it has alpha cells, and it has delta cells. Of the 3 types of cells, the largest, or the one that constitutes the largest amount, is the beta cells. Meaning that if someone asks you what is the major function, if we had true false, what is the major function of the pancreas? The pancreas is mainly responsible for digestion. The more the cells you have, the more clear or meticulous your function is derived. If someone told you that we are having an anterior pituitary gland here, what is the major function of the anterior pituitary gland? Ladies and gentlemen, it's growth. Why? If you are to look at gonadotropes, somatotropes, lactotropes, corticotropes, the cell in histology of the anterior pituitary gland that dominates the anterior pituitary gland are the what? Somatotropes, which produce growth hormone. So the major function of the anterior pituitary is growth. So the major function of the pancreas here would be digestion. But if we look at the islets of Langerhans, the major function of the pancreas, the endocrine pancreas in particular, is glucose homeostasis. So the beta cells produce insulin, the alpha cells produce glucagon, and the delta cells produce somatostatin. So it is important for us to remember that the beta cells are the ones that will be stimulated by glucose under what we call the glucose-mediated insulin release for the beta cells to produce the insulin. Now, I'm just going to give you a brief idea on how your beta cell is producing insulin right now. We have agreed that when you consume a diet rich in carbohydrates, the carbohydrate is broken down to liberate for you what? The glucose. The glucose is absorbed, and then it will come to the beta cell. When it gets to the beta cell, it stimulates the beta cell to produce, yes. Hello?
Yes, please.
Oh, sorry, I was attending to something here. So let's let's quickly get done with this and look at something else. So we have said that when glucose is absorbed, the glucose will stimulate the beta cell to produce insulin. But how does that happen? I want to quickly remind you about what your anatomy and physiology says about protein hormones. Protein hormones, protein polypeptide, vis-a-vis those derived from tyrosine or tryptophan, or those of cholesterol, what usually happens is that they are produced, they are synthesized and stored, as compared to those produced from cholesterol, which are synthesized on demand. So if we are to take, for example, insulin is not produced at the time when glucose enters the cell. No. In fact, insulin is produced and stored, awaiting for a stimulus that will result into its release. I hope I am clear. So in this particular case, when glucose that has been absorbed enters saturation and is taken to the beta cell, when it gets to the beta cell, glucose transporters, remember we have agreed that wherever you find glucose, glucose uptake is facilitated by a special type of proteins called the glucose transporters. Glucose transporters range from glucose transporter 1 to glucose transporter 5. You can go and read about them. Where do we find which type of glucose transporter and what is their function? And the other important thing is that type of glucose transporter influenced by insulin or not? So we have two major types of glucose transporters, those that are insulin dependent and those that are insulin independent. So if someone has low amounts of insulin, like we have seen in DM type 2, the non-insulin dependent glucose transporters will not be affected. For them, they will continue operating because they don't need insulin to cause glucose uptake by that particular tissue. The specific type of glucose transporter found on the beta cell is called glucose transporter 2. And by the way, you should have come across these glucose transporters. They're usually abbreviated as GLUT in uppercase, and then a number at the end to differentiate between the different types of glucose transporter by the tissue where they are found. So we have GLUT-1, GLUT2, GLUT3, GLUT4, GLUT5. The GLUT found on the beta cell is GLUT2. So when our glucose gets to the beta cell, GLUT2 causes uptake of glucose, and glucose enters the beta cell now. In the beta cell, glucose is used by glycolysis to synthesize ATP. That is biochemistry. I won't take you through these details. This is introduction to non-communicable diseases. So we have now synthesized the ATP. What will the ATP do? The ATP will be used to close the ATP-sensitive potassium channels. Remember, every cell is excitable, only that some are more excitable than others. Every cell has a resting membrane potential, whereby we have this number of ions on this side, this other number of ions on this side. As a result, that cell can't be excited in that state. If we are to take the beta cell, for example, if the ATP synthesized within the beta cell causes the ATP-sensitive potassium channels to close, what are we doing? Class, what are we doing? I'm going to give you two terms. Are we depolarizing or we are hyperpolarizing?
I think we got lost somewhere there, to be honest.
Hey, by the way, this is anatomy and physiology. It's not supposed to be discussed.
Yes,
here.
Mr. Samuel, but it is too detailed. We
Really?
go flowing, then at some time you lose us, then we catch up later like that. Yeah, seriously.
Okay, so Stuart,
Hope I'm not alone in this.
Where should I start from? I want to repeat for you.
I was trying to understand the glucose transporters, then you went too far now. I couldn't understand anything there.
Glucose transporters, we have said, are the ones that aid glucose uptake by the different tissues. Stuart, every cell that uses glucose must have a glucose transporter on it. But what you need to learn, how you need to approach the glucose transporters, Stuart, and the rest of the class, is which of those transporters is influenced by insulin and which one is not. So whenever we are talking about problems that come from not having sufficient insulin, like DM type 1 or like DM type 2, where the insulin was initially a lot and then it became little and can even completely disappear if you don't intervene and manage the patient. Those problems originate from which of the transporters is influenced by insulin or not. Stuart, is that clear?
Yes, a bit clear now.
I hear a bit clear. Stuart, what you're going to do is you're going to wait for me after the class. I'm going to send you some notes on glucose transporter, like 2 slides only, a PowerPoint of 2 slides. You look at the glucose transporters and understand them better. I'm going slowly, step by step, so that you can understand, because later on we are going to say the mainstay oral hypoglycemic agents are the sulfonylureas, where we have glyburide, glipizide, glibenclamide, etc. And then I'll tell you, they act like, they initiate mechanisms to manage DM using the glucose-mediated insulin release mechanism. Then now you start fighting me, saying some is mentioning abstract things. That's why I passed via the normal before we continue diagnosing DM. So now, Stuart, glucose transporter 2 or GLUT2 is the one particular found on the beta cell. So when glucose arrives at the beta cell, GLUT2 facilitates uptake of glucose by the beta cell. In the beta cell, ladies and gentlemen, remember glucose is a biomolecule according to your biochemistry. But then what I want to bring to your attention is that glucose is a raw material for energy synthesis. The one who taught you biochemistry should have told you fat can be used to manufacture ATP, glucose can be used to manufacture ATP, proteins can be used to manufacture ATP. But the most usable form of energy comes from glucose. And we can produce glucose, especially in aerobic. We can produce glucose with the least complications. What do I mean? The byproducts of metabolism are not hazardous to the body. going to be heat and water. So that's why you see in normal, we usually call on glucose than calling on fat. And we're going to see the dangers of calling on fat, especially in diabetes mellitus, where we have such compensatory mechanisms. So when the ATP is synthesized from the glucose that has been taken up by the cell, and I am saying that the process that results in ATP synthesis by this cell is glycolysis. The ATP formed is going to close the ATP sensitive potassium channels. Let me assist you here, Stuart and the rest of the class. Ion channels can close due to very many things. For example, change of concentration of ions on either side of the cell can cause a channel to close. But then the presence or absence of ATP can cause a channel either to keep open or to close. In this particular case, the ATP synthesized will stimulate closure of potassium channels. And my question is this: keeping in mind what sodium channels do and potassium channels do, if you close the potassium channels on a cell, are you depolarizing or hyperpolarizing the cell? Flavia, Lily. Flavia?
Yes, sir.
Are we depolarizing or hyperpolarizing?
I think we are hyperpolarizing.
Okay, you think we are hyperpolarizing?
I think
Yes.
we are depolarizing.
You think we are depolarizing? So now we have depolarizing and hyperpolarizing. Let's get one more. Who will be the tiebreaker? Jolie? Hey, Derek, come and mark Jolie absent. Immaculate?
I think we are depolarizing.
What is depolarization in this case? Or what would qualify this scenario for depolarization? Okay, Immaculate, when oh, you guys are struggling. Okay, let me assist you. To depolarize a cell, we need the amount of positive charged ions within the cell to increase. Why? Remember, when a cell is in resting membrane potential, ladies and gentlemen, we have the outside more positive than the inside, meaning that in resting membrane potential, the inside of the beta cell should be negative and the outside of the beta cell should be positive. How is a resting membrane potential maintained according to anatomy and physiology? We have the sodium potassium pump. So you have sodium being pumped outside, potassium being brought inside. Or you can do it using other ions, whereby, for example, if you wanted to depolarize the cell, instead of bringing in sodium, you can stop the potassium from flowing out. Because, ladies and gentlemen, if you stop the potassium from flowing out, automatically the potassium within the cell is going to build up. The building up of the potassium within the cell is going to move it from the minus where it was in resting, and it will bring it close to zero, which is sufficient enough to what? To initiate an action potential. Am I making sense? Is there anyone who is understanding what I'm saying? Derek, are we there?
Yes, we are.
What is the problem? Are you following? All
Yes,
things have become hard.
We are following.
All right. Guys, you have the right to unmute and ask or drop something in the chat. I'm constantly checking there, so that will repeat for you than just moving on. Because when we move on, you'll be the one who is left behind. Now, whenever we depolarize a cell, what is the next thing? If we are to take, for example, it's a neuron. enough. Yeah, let me use neuron. Let me ask. Lubega, please mute. Derek, can you mute? I want to ask you a question.
Okay, sir.
Okay, so Derek,
Yes,
whenever we depolarize it, let's take a neuron. A stimulus has come. It has stimulated. Let's take ligand-gated sodium channels. The sodium channels have opened. Sodium ions have entered the cell. When the cell gets depolarized, what is the next step that is going to happen? So as to enable the release of whatever mediator is supposed to be released by that cell. For example, in the beta cell, we want to release insulin. After depolarization, what is stimulated that will result into the release of insulin?
I think it is permeability. Like the ability of the cell to allow things to come in. And also maybe due to the having less ions inside and much more outside.
Okay, thank you, Derek. I think now I can officially agree that the anatomy and physiology is what is disturbing us. So in the slides I have uploaded, I uploaded some content on the study platform on Moodle. I will maybe remove some and add others that have some bit of the anatomy and physiology in them so that you do not miss out. Whenever you depolarize a cell, ladies and gentlemen, the next thing that the depolarization does is that it stimulates calcium channels. So whichever way in which you depolarize, and we have said we have two examples. You can depolarize your beta, you can depolarize a cell by opening sodium channels and allowing sodium, which is positive, to enter inside the cell where the inside of the cell was more negative. This builds up the positive charge within the inside of the cell and brings it close to zero, because remember, we're coming from negative. And remember, the degree of negativity varies for a cell. Some cells are at minus 90 millivolts, others are minus 55, like that. But our business here is the negative must draw close to the positive. And when we get close to zero, we depolarize. Depolarization means an action potential being set up. Immaculate mute. So the action potential set up in the beta cell, ladies and gentlemen, is going to stimulate the calcium channels to open. Calcium channels are voltage gated, so they respond to changes in voltage across the cell. So when the calcium channels get open, they will allow an influx or inflow of calcium into the beta cell. What the calcium does once it enters the cell, it is going to fuse with the vesicles that have insulin in them. Remember, we said earlier on, insulin is synthesized and stored. That synthesis of insulin, since it is a protein, it means we shall have the role of the DNA, so that we have transcription into messenger RNA. The messenger RNA will live via the endoplasmic reticulum, go to the ribosome, we synthesize, package, and store. So when the calcium enters, these vesicles that have insulin in them fuse with the calcium, and they are transported to the membrane of the beta cell, and then we have exocytosis of insulin. That is it. So glucose, the take-home point here is insulin secretion by the beta cell is influenced by the glucose you take up. The more glucose, ladies and gentlemen, we take into the body, the more insulin we expect the body to produce. I am bringing this to your attention so that you understand how, for example, the postprandial glucose test, or what we commonly refer to as oral glucose tolerance test, works, where we get an individual, measure his baseline blood glucose, give him a 75-gram dose of oral glucose, and then every after 2 hours measure. Why are we measuring the blood glucose? We are measuring blood glucose using the physiology of the beta cell in response to blood glucose, that each time you give glucose, glucose. Yes, Stuart, you're going to be enrolled. Hello? Stuart, yes. Are you hearing me?
Yes, yes, please, I'm hearing you.
Yes, I was only, my intention was to only enroll you when I've put up the material. And now I've populated the site, I can enroll you. So that shouldn't be an issue. That shouldn't be a problem. So I am saying that we are covering this normal so that we can understand, for example, how an oral glucose tolerance test works. That we give someone a 75-gram load of glucose, and after every 2 hours we measure. The idea is that we know that once glucose enters, that glucose stimulates the beta cell. The beta cell produces insulin. Insulin stimulates glucose transporters, where the glucose transporters are insulin dependent, and the glucose transporters cause the glucose to be taken up by the cell. That is the normal, and that's why we are talking about it. So you are able to tell, after giving someone 75 grams of glucose load, after 2 hours, if these blood glucose levels are still so high, like we shall see the ranges, usually greater or equal to 11.0 millimoles per liter, then you can say this guy is having hyperglycemia. And the test repeated after a given period of time, you can diagnose and say this guy has diabetes mellitus. Why? We know the normal. The normal is each time glucose enters circulation, the beta cell is stimulated to produce insulin. After 2 hours, the glucose should have reduced. Am I convincing someone, or I am convincing you? Confusing you, sorry. Are you convinced or confused?
Yeah, convinced.
Class, are we together? Chirumira Paul, are you there? Is Chirumira there? Derek, come we mark Chirumira absent.
When I was learning, was on a 3G network.
I saw him. Chirumira, you're just a show off here, 3G network. So let us proceed. Now, what are the types of diabetes mellitus? Oh, by the way, I am not covering this, but I'm assuming that you remember the role of glucagon. Insulin, we have seen. Insulin stimulates glucose transporters that are insulin dependent, cause glucose uptake. What is the role of glucagon? You get? So that is what you should be having at the back of our mind. If a patient has, is there a time in a patient who has diabetes mellitus where we may need to give glucagon? So once glucose comes, glucose facilitates uptake. Once insulin comes, it facilitates uptake of glucose by the cells. Some of the cells that take up glucose are like the liver, and in the liver, the glucose is converted to glycogen and it is stored. So if someone were to ask you lightly, what is the function of glucose? Glucose decreases, the function of insulin. Insulin decreases blood glucose. Glucagon increases blood glucose. Somatostatin regulates both insulin and glucagon. So that should give you an idea. Insulin decreases blood glucose, period. Don't suffer a lot looking for very complex answers. Insulin decreases blood glucose. Glucagon increases blood glucose. Somatostatin, the one of the delta cells, regulates both insulin and glucagon. We won't go into those particular details. So let's look at the types of diabetes. We have all unanimously agreed that we have two main types of diabetes mellitus. The thing that we didn't mention is that there are other forms of diabetes mellitus that have been registered. So the two major types of diabetes mellitus are DM type 1 and DM type 2. Previously called the type 1 being called the insulin-dependent diabetes mellitus, and type 2 being called the non-insulin-dependent diabetes mellitus. I would like to draw to your attention that this classification has since been eliminated because it was misleading. For example, most people think that the non-insulin dependent diabetes mellitus, which now took on the name DM type 2, should not be managed using insulin. And this is wrong. We have very many type 2 DM patients who are on insulin and they are responding. In fact, in type 2 DM, we have two forms of management, the insulin and oral hypoglycemic agents. So don't be surprised by finding a physician who has introduced your DM type 2 patient on metformin and is also receiving injectable what? Insulin, because it is indicated. The other thing I want to draw to your attention is gestational diabetes mellitus and secondary diabetes mellitus. The gestational diabetes mellitus is the type of DM that occurs in pregnancy. What do I mean? Initially, the woman had a normal glycemic control, non-diabetic, but because of certain pathological changes that occur in pregnancy, the woman becomes diabetic or develops diabetes mellitus. My question would therefore be, in DM type, in gestation diabetes mellitus, what is the type of picture that we experience? Is it more of a DM type 2 or a DM type 1? Members, gestational DM, does the patient present with more of type 2 or more of type 1?
Type 2.
Type 2.
Yeah, more of type 2.
Okay, type 2. How do we manage? Is the management more of type 2 or type 1?
Type 2.
Jolly Chiboko. Jolly Chiboko. So we are going to look at, we shall have something brief. I will upload something brief for you on gestation diabetes mellitus. So we have seen type 1, type 2, gestational or pregnancy induced. And then the last type is secondary diabetes mellitus. Now with secondary diabetes mellitus, what you need to know is that the patient is having a known pathology that is causing hyperglycemia, or that is causing a persistent hyperglycemia. So in this particular case, we are saying that the patient could be, for example, taking drugs. For example, the patient could be taking sympathomimetics. The patient could be taking corticosteroids and the likes. The patient could be having tumors. The patient could be having, the tumors could be of endocrine glands that play a role in glucose homeostasis. The patient could be having endocrine disorders. For example, Cushing's disease or Cushing's syndrome. All of these would result eventually into chronic hyperglycemia. The unique thing, however, with secondary diabetes mellitus is that if you manage the cause, the patient usually goes back to normal glycemic control. The same with gestation. Most mothers who develop pregnancy-induced diabetes mellitus, if you adequately manage them, they will go back to normal glycemic control. However, if they're inadequately managed, just like pregnancy-induced hypertension or preeclampsia, the mother can develop residual complication. That means you have a mother who has preeclampsia and eclampsia. If you inadequately manage them, then they eventually develop what? Hypertension, even after termination of the pregnancy. It's the same thing here. So each time you get a mother with gestation diabetes mellitus, you need to manage in a rigorous manner to ensure that the mother does not develop complications after they have given birth. If there are midwives in this class, they will tell you that because of the abnormal glucose homeostasis in a mother who has pregnancy-induced diabetes or gestation diabetes mellitus, there is usually higher risk of these mothers producing big babies who are hypoglycemic, and we end up with what? With complications in the newborn. That you look at when you're looking at the slides I'll share with you. Let's look at diagnosis. How do we make a diagnosis of diabetes mellitus? Who can guide us?
Pardon?
We want to make a diagnosis. How do we make a diagnosis of diabetes mellitus? What are the different ways in which we can make a diagnosis of diabetes mellitus? Yes, Justin.
Okay, thank you, Sam. I think we can do a glucose level by doing a blood test, whereby we can do fasting glucose test. Then there is where also they do random glucose test to see if somebody is having diabetes.
Okay, thank you. Anyone else? Thank you very much, Justin. Anyone else?
So, Mia, I think also from the signs and symptoms that the patient presents with, it's the first.
Talking?
Esther Nansubuga.
Esther, thank you very much. In fact, I am about to shift the academic medal and hand it over to you, or I think I'll have to organize another one. Each time we talk about diagnosis, guys, don't run to investigations. Each time we talk about diagnosis, I know some of you are there seated saying, but some has not talked about the symptoms and signs of diabetes. That's diagnosis. Each time we talk about diagnosis, there are certain diseases that have what we call pathognomonic features. So pathognomonic features are classical signs and symptoms, which if present or absent, can be used as a means to either diagnose or rule out presence or absence of a certain disease. And diabetes mellitus is one of those diseases which has pathognomonic features. So symptomatology, ladies and gentlemen, is very important as a diagnostic criteria in diabetes mellitus. Don't forget that. When you have a question asking you about diagnosis, don't run to, I'm seeing people saying fasting blood sugar, random blood sugar, HbA1c, all these are okay, they are good. But first things first. So under symptoms and signs, I want to classify for you diabetes mellitus at this point. That the patient of diabetes mellitus can present in an acute or chronic state. The acute forms of diabetes mellitus, a patient can present either in hyperglycemia or hypoglycemia. Let me repeat that. A patient of diabetes mellitus can present in acute or chronic state. Let me give you an example. Some of you have seen even some of these occurrences. A DM patient can come to the eye clinic, or a DM patient can come to the chest clinic. So if you come to the eye clinic, you can come complaining of blurring in vision. Their accommodation for either near or far has changed. When they are looking at the chalkboard, they get a bit of blurring, the letters are not that clear. And then if you carried out a random blood sugar in this patient, you can find the patient has 30 millimoles per liter. But what has brought them is not diabetes mellitus per se. It's not the hyperglycemia. What has brought them are the ocular manifestations. So what you're looking at that particular moment, you are having a patient of diabetes mellitus who has come in complication of diabetic retinopathy. But they have come to you. A patient can come to you, females usually come when they are having repeated non-responsive to standard treatment vaginal candidiasis. A patient can come to you with the styes. What is a stye in the local dialect? But a patient can come to you with chronic size. A male can come to you with chronic balanitis, inflammation of the glans penis, and they are circumcised, and you'll get stuck and wonder. Or a patient can come to you with even chronic UTI. So you have to possess what we call a high suspicion index to understand that DM can actually present in the acute phase or chronic. Because for us, the type of diabetes mellitus we are accustomed to is the acute, where a patient comes either in DKA, in hyposmolar hyperglycemic non-ketosis, in hypoglycemia, etc. No, a patient can come and his only complaint is inability to maintain or sustain an erection. High suspicion index means that you will not manage the inability to maintain or sustain an erection as an isolated condition. I have seen it. Patients walk into the clinical room, the clinician listens to them and prescribes Viagra for them. Don't do that. Because ideally, this inability to sustain an erection cannot be an isolated symptom. It must be a presentation of a bigger underlying condition. So by the time a DM patient comes to complaining of impotence or erectile dysfunction, their disease has progressed for a long period of time in that the autonomic nervous system has now been what? Affected. So a DM patient who comes with erectile dysfunction is actually presented with what we call a diabetic neuropathy. So there are very many, there are cocktails of manifestations that can tell you if a patient is in the acute or in the chronic state. So when we are talking about the signs and symptoms, the symptoms and signs of diabetes mellitus, we should remember that the patient can either come in acute or chronic. The common manifestations, however, of diabetes mellitus are the 5 P's and 3 W's. That's the mnemonic we use, 5 P's and 3 W's. So we have polyuria, we have polyphagia and polydipsia, pruritus and paresthesia. Let me repeat. We have polyuria, polydipsia, polyphagia, pruritus, itching, and paresthesia. And the 3 W's are wasting, weakness, and weight loss. Wasting, weakness, and weight loss. So these can be coupled with these can be coupled with presentations of the chronic manifestation of diabetes mellitus, where the patient can have features suggestive of kidney disease, patient can have features suggestive of heart disease, patient can have features suggestive of retinal pathology, patient can have features suggestive of neural damage, etc. So a patient can come to you when he's having pins and needle sensations in the fingers and in the feet. Don't manage this in isolation of diabetes mellitus. Diabetes mellitus is one of the common causes in practice of paresthesias. So rule out the diabetes mellitus by, for example, asking if they have these other symptoms and signs. Do they have polyuria? Do they have polydipsia, etc.? If they don't have, or they're uncertain, then go to the next phase of the diagnostic criteria, which is the investigations. So now most of you have listed the right investigations. What is important and what you'll be assessed about in the examination, but then also what you need as a practitioner if you're going to conduct, for example, an NCD outreach and we are doing screening. What is important for you is to understand the cutoff points and the normal ranges. So some of the common investigations carried out include things like the fasting blood sugar, random blood sugar, oral glucose tolerance test, or a postprandial glucose test, and then the glycated hemoglobin or the HbA1c. Now remember, the cutoff values are very important. Random blood sugar is usually greater than 11.1 millimoles per liter. The cutoff, I usually remind my students that the cutoff for random blood sugar and the postprandial glucose tolerance or the oral glucose tolerance test is the same. The patient will have greater than 11.1 millimoles per liter. The fasting blood sugar is usually greater than 7.0 millimoles per liter. You can have these values in either millimoles or milligrams per deciliter. If you have milligrams per deciliter and you are well versed with millimoles per liter, just divide by 18. If you have millimoles per liter and for you are well versed with milligrams per deciliter, multiply by 18. But the current, where is Jolly? Jolly? Jolly, where are you?
Yes, sir.
Jolly, what is the current recommended unit for blood sugar? Is it millimoles per liter or milligrams per deciliter?
Millimoles per liter.
Excellent. So ladies and gentlemen, the recommendation has now shifted from milligrams per deciliter to millimoles per liter. The other thing I want you to pay attention to is HbA1c or glycated hemoglobin. We have always been reading HbA1c, for example, the cutoff for diabetes mellitus is 6.5%. Anything greater than that. The current recommendation, however, is convert the percentage into millimoles per liter. So currently we are reading our HbA1c not in percentage, but in millimoles per liter. Do not forget that. I am mentioning this because I will assess according to the current best practices. That is why I'm teaching them. And that is why I'm calling on Jolly and the other people I'm calling on. I'm calling on Jolly because I know where she works. And I know the type of people she interacts with and the kind of knowledge that she has that she can share with the whole class so that we all benefit. So when you get to the examination, please don't write for me HbA1c in percent. You'll notice that the material I've uploaded on Moodle has the millimoles per liter in it and the percentage in brackets. Don't write for me random blood sugar, fasting blood sugar in milligrams per deciliter. I want it in millimoles per liter. And I have given you the trick. If for you, you mastered them in milligrams per deciliter, divide by 18, get the answer and write it. So the other important thing I want to draw to your attention is this. Like we said when we were looking at hypertension, each time you know a normal range, it is very easy for you to capture a category of patients, of clients that we usually ignore. Those are the clients who are at the middle ground. They are not normal, they are not sick. So there's a category of clients in diabetes mellitus management called the pre-diabetic patient. We usually make a diagnosis of pre-diabetes mainly using the fasting blood sugar. Fasting blood sugar. Don't forget that because someone can ask you. So it's very important for us to remember that because it will eventually help us in making a decision on which patient or which client we need to spend a lot of time with, in which client we may need to initiate treatment, even if they don't actually have the frank diabetes mellitus, and so on. So currently, patients with prediabetes are introduced on at least one drug, usually metformin, that is in type 2 diabetes, along with the lifestyle and dietary recommendations and so on. So I want to remind you, like I did introduce the concept when we're looking at hypertension, that when you're talking about investigations, remember that in one category of investigations can be aimed at giving us the actual diagnosis of the condition we are dealing with. But then the other sets of investigations can be targeting the cause or they can be targeting the complications. So for example, random blood sugar, oral glucose tolerance test, fasting blood sugar, glycated hemoglobin, all of these are targeting on making a diagnosis of the diabetes mellitus. However, a fasting lipid profile, abdominal ultrasound scan, targeting the pancreas, targeting the kidney, targeting the adrenal gland, dexamethasone suppression test, things like thyroid stimulating hormone, thyroid function test, where you look at T3, T4, TSH. If you look at these, some of them, they are targeting the cause, others are targeting complications. So don't be surprised if a physician orders for renal function test in a patient in whom you have made a diagnosis of diabetes mellitus. Don't say, this physician is just wasting the patient's money. No. In actual sense, by ordering for renal function test, the physician is trying to check if this long-standing undiagnosed or poorly managed diabetes mellitus that the patient has been presenting with, if it has actually affected the kidney. I hope I am making sense. When we are approaching investigations, I'll repeat, a category of investigations can be to make the actual diagnosis. Another one can be aimed at looking at the cause or etiology. Another one can be aimed at looking at the complications. All of these you must know. Because if you're going to initiate your programs, you need to know how you're going to screen the population. And if you're using a screening test, what is it looking for? Are you screening causes? Is your test screening causes? Is it screening complications? Or it is screening the actual diagnosis? All this you need to have an idea about. So finally, let's talk about management of a patient with diabetes mellitus. What is the practice? As a public health practitioner, how would you approach management of patients with diabetes mellitus? I am seeing someone saying, when we get to the exam, we just look for where Jolie is seated. Stuart, I am the only one permitted to make jokes in this class here. So stop trying to intimidate Jolie.
I'm sorry.
No. That's a joke also. Can we manage diabetes mellitus?
Can I give an answer?
Yes, please.
It's okay. Yes. We try to identify to it. Yes. In the management, we try to identify what caused it or what predisposed it. Then we deal with that, like the predisposing factors which we saw. Especially the modifiable ones, we try to modify them to suit our goal of bringing down the blood sugar.
Okay, Stuart, I agree. You can identify the etiology. Remember, members, we said in type 1 DM, the problem is usually autoimmune disease. Autoimmune disease is to a certain extent controlled by genetics, but most autoimmune disease is in response to certain pathology. So a patient can suffer from mainly viral infections are the ones that can cause some of these complications. So you have a disease to which in a response, the body produces autoimmune antibodies, and these autoimmune antibodies target specific tissue or specific cells. So like in type 1 DM, it is the pancreas that will be targeted. But what I want to amuse you about, most patients who have type 1 DM, where we are faulting autoimmune pathology, they usually have other autoimmune pathologies going on in their body. So it's important. If you want to consolidate your diagnosis of type 1 DM, obviously we have used the age, less than 35 years. We have said the autoimmune, there is a disease that should have triggered an autoimmune pattern, or you can even assess and test for the autoimmune antibodies and see them. In this particular case, there will be anti-beta cell autoimmune antibodies present in the circulation. You can look at, you can measure the amount of insulin. I'm helping you now make a diagnosis of type 1. Or if you had a case scenario, how you'd be like, I am sure, beyond a shadow of doubt, what we are dealing with is type 1. We can measure the amount of insulin. Now, most of our labs don't measure insulin directly, but they measure something like a proxy measure. In the synthesis and release of insulin, we start with the pre-proinsulin, proinsulin. From proinsulin, we manufacture two proteins. We manufacture insulin and a connecting peptide, also referred to as a C-peptide. So what the laboratories do, MBN, mainly Lancet is the one we have ordered for C-peptide levels. So what Lancet usually does is, Lancet will measure for you the C-peptide levels. C-peptide, also called the connecting peptide or connecting protein, is produced from proinsulin. in equimolar amounts as insulin. What I mean by equimolar is when you break down proinsulin, you produce the same amount of insulin and the same amount of C peptide, meaning that even if we don't have the ability to measure the insulin, if you measure C peptide, you can adequately comment about the amount of insulin the patient has. So the other way of deciding if this is type 1 or type 2, and in this particular case, we're inclining ourselves to type 1. We have said age of onset, presence of anti-beta cell antibodies in saturation, history of an infection that triggered the autoimmune disease, usually viral infection, presence of other autoimmune diseases in this particular individual, the levels of C peptide in the individual. All of these will tell you that this particular patient you're dealing with is a type 1 DM patient. If we want type 2, age of onset, usually greater than 45 years of age, the amount of C peptide will tell you that this patient is having some insulin being produced vis-a-vis the amount of C peptide we saw in type 1. All these are in the slides I uploaded on the platform. Very clear and easy for you to understand and interpret. Then we shall look at the family history of DM in that particular individual. So if you're interested in someone and tell you, my father died of diabetes or my mother had diabetes, then you are able to understand that most likely what you're dealing with is a diagnosis of DM type 2. And all these other things that we have discussed along the way. The individual is obese. They will respond to both insulin and oral hypoglycemic agents, which is not the case in type 1. The patient who is given oral hypoglycemic agents will keep on deteriorating. So all of that we are basing on what Stuart has told us. Identify the cause and start from there. What other way can we handle this? Cotias is saying design a diet plan that comes with managing diabetes. Yes, I entirely agree. And you're going to see that we call it the diabetes pyramid. Jolie, I will also request you to share what your facility is doing, because your facility is actually a wellness facility. So it should be dealing on the public health. It should be emphasizing a lot of this public health intervention. So you will share what is being done, and the class should definitely benefit from that. Paul is saying administer insulin. Paul, I entirely agree with you. And some of the things you should be able to understand as a medical worker or a health worker is in which cases is the insulin. So you should be able to decide which patient needs insulin and which patient does not need insulin. And this is where the biggest challenges are originating from in practice. First of all, on the client side, you guys who have managed DM patients will agree with me that each time you tell a DM patient that insulin is indicated in treatment, immediately the patient gets extremely worried, because people believe that being put on insulin is a death sentence, which is not the case. Only if, okay, it's still not the case. Let me not say only if, it is not the case. However, in type 1 DM, we have nothing to do. The patient must be on insulin for life. But in type 2 DM, there are several patients personally that have introduced on insulin until their pancreas has regenerated and stabilized. So it's important for us to remember that someone can ask you, why are you introducing insulin in this patient? The most obvious answer, in this particular case, would be if the patient is a type 1 DM patient, introduce insulin. However, we can have type 2 DM patients in whom we may need to introduce insulin, and there you'll need to defend what are the cutoff values on fasting blood sugar and glycosylated hemoglobin for which we can use to initiate a patient on insulin, a DM type 2 patient. So for the DM type 2 patient, where we ideally expect the patient to be responding to oral hypoglycemic agents, you need a sound justification to say, the HbA1c of the patient was 16.5. And anything greater than 12, we can administer insulin injection to the patient until the patient stabilizes, and then we switch them back to oral hypoglycemic agents. You'll see this and more in the slides I shared with you. So Koshia said the management depends on the type, okay? Paul says diet and exercises, oral hypoglycemic agents. I entirely agree. So usually we use the mnemonic needs. The mnemonic needs. Needs in full is nutrition, education, exercise, drugs, and self-evaluation. Have we all understood needs?
Yes, sir, but more light on the self-evaluation.
Okay, so in the needs, we are saying nutrition, we've all understood. I hope you all have an idea. If not, we shall look at the slides I've shared. But nonetheless, we expect that if someone is going to consume carbohydrate, for example, he does not consume anything greater than the size of their clenched fist. That is what we have been doing. If there are any other approaches, the flow is open. But usually, personally, what I tell my patients is the total carbohydrate consumed in diet should not exceed a clenched fist. Should not exceed a clenched fist. So that means all the rice, all the Irish, all the posho, all the millet, because you see, the biggest challenge with management of diabetes mellitus, and you people can bear witness, is the clinicians, the physicians spend a lot of time telling the patients what they should not eat than telling them what they should eat and how they should eat it. So the approach currently says, you can eat this, you can eat that, and the other. However, the amount should not exceed this. So if someone wants to eat some rice and wants to eat some Irish, clenched fist is the size they should consume in a single sitting. The other issue is that their diet should be rich in a lot of vegetables, rich in a lot of fruits, but then we shall be very specific on the fruits and say that the fruits that have a lot of sugar in them should be avoided. So you will find that the diabetologists will recommend more of apples. If they are to consume bananas, they recommend more of the bogoya instead of the small bananas, because the small bananas have a lot of sugar in them. However, if you have a DM patient who's going into hypoglycemia, why not? They can eat these small bananas. They can eat a slice of watermelon, though in the routine wouldn't recommend this to be part of their diet. The diet should be low in the saturated fat and should be high in the protein. So this, with the time, it becomes very easy for you to juggle if you have been recommending the patient to consume or if you've been prescribing it. So the more you indulge in this type of prescription, the easier it is for you to understand how it is done. Now, exercise, you look at the schedule that I've shared with you, brisk walking, gardening, jogging, but we are saying at least the exercise should be greater than 30 minutes, and it should be most of the days in a week. For my patients, I usually recommend at least 4 days. Jolly, what does your facility recommend in terms of exercise? How many days?
Walking.
And for how much time? So you recommend jogging?
Walking. They are old.
Oh, okay. Most of your patients can't jog. Okay, fine. So walking, they can cycle if they can. My dad rides a bicycle and is around 75 years of age. He rides a bicycle. So if they can ride, but then don't recommend, this should not be a recommendation that cuts across. You want even someone who is deep into Ruhura, who goes to the garden every day, you want them to jog or to walk. No. So if someone is gardening, that is exercise enough. So we just recommend that they don't strain a lot, especially if they are taking insulin. The recommendations will change a bit to not engage in any physical activity after consuming the insulin, because it can increase on the occurrence of hypoglycemia in this patient. So education, mainly you tell the patient about the disease, but in particular, we're interested in telling the patient about symptoms of acute states. So you notice that at the DM clinic, we are telling patients about symptoms of hypoglycemia, especially those who are on insulin, and how they should intervene. So that is very important for you to share with the patient, because one of the leading causes of hypoglycemia and diabetes mellitus is actually insulin. Drugs are divided into two major classes. You have the oral hypoglycemic agents and the insulin. Insulin is divided into the ultra short acting, the short acting, the intermediate acting, and the long acting. However, we have mixed or mixed preparations where you can have an intermediate and long acting type of insulin. You should be familiar with which type of insulin is used in the emergencies. Usually the intermediate and long acting are not recommended for use in the emergencies. And when I talk about the emergencies, I'm looking at the hyperglycemic emergencies where we have diabetic ketoacidosis or the hyperglycemic hyposmolar non-ketosis. So in this particular case, we usually recommend the utilization of regular insulin as a type of management. But then you can also go to your respective, Derek was telling me that most of your clinicians. So you can walk into your pharmacy and look at the different types of insulin. Which insulin is clear solution? Which insulin is turbid or cloudy? And what makes it turbid? Which addition, what has been added to the insulin that makes it turbid, and for which purpose has that addition been made? So most of the intermediate and long-acting insulin has some form of addition or augmentation that retards the release of the insulin, and that's the reason that gives the insulin its typical long duration of action. That is something you can find out. And then finally, self-evaluation. So under self-evaluation, like Derek was asking, we're mainly targeting what can a patient do to contribute to their well-being in terms of this particular condition. So some of the things we do in self-evaluation is teach a patient how to use a glucometer, how to interpret glucose results, and how to administer insulin in response to the interpretation of the glucose results and documentation. Documentation is very important, especially for patients who are on insulin regimen. It's actually paramount that your patient records their blood glucose level properly each time they are going to administer insulin, because it will help you as a clinician to make a judgment on the insulin requirements of the patient and the any titration in response to the insulin. The next thing is to identify, under self-evaluation, to identify complications. And I gave an example of hypoglycemia. If a patient takes insulin and is going into hypoglycemia, they should be able to identify that my heart is going to race, I'm going to sweat, I'm going to develop tremors, and I'm supposed to respond by taking an eclair, taking a lollipop, eating a small banana, drinking half of Fanta orange, etc. Self-evaluation. The other thing, some other complications we usually recommend our patients look out for are things like diabetic foot or diabetic ulcers. So recommend every morning when the patient is done showering to put a mirror under their foot and look if there's any, look for any discoloration on the soles of the feet, and if there's any discoloration, to report this. Any cones that have developed and how this should be managed. We usually recommend on the footwear, when to buy shoes. For example, if you go out to buy shoes, which size, which type of shoes you should put on. We usually discourage heels and wedges, and we usually recommend the patients put on flat shoes. There's a debate on whether the patient should put on open shoes versus closed shoes, but personally, I think the closed shoes would be better because you reduce on the chances of injuries to the feet, which can easily trigger diabetic ulcers, especially if your patient is poorly controlled for their blood glucose. Are there any questions on needs in management of diabetes mellitus? Derek is talking about indoor table tennis. Some of these things, Derek, are not feasible. Remember when you're making recommendations, like the practice I've seen with the facility where I work, where we have a diabetologist. the practice is that he first inquires from the patient what their staple diet is. Let me use nutrition. And it is based on the staple diet or their regular consumption, the food they regularly consume, that they make the modifications. So if someone is deep in Pungamo, where are they going to get table tennis from? They are not. But if they are able to leave their home and go to the garden and dig, that is enough exercise. Walking to the garden, digging, and walking back home. They don't need to go to the gym or do any other. And then you also want to initiate an intervention that is sustainable. If you tell a DM patient who is obese to lose weight, and they are telling him to go and do aerobics in the gym, how sustainable is gym practice? Timing, first of all, the inconvenience. I stay in Naguru and I go for gym in Chanja. How practical is it? So these are some of the things you need to keep at the back of your mind and when you're initiating intervention for a patient. Any questions?
Thank you. So I'd like to also look at initiating these people to the NCD clinic, and also we need to assess at what level this patient is in. Could be a new diagnostic pattern, a newbie, could be a defaulter. So I believe we also need that intervention to identify if someone is new, how we take them to them. If someone is a defaulter, we find out why did they default, how could we position to help these people. And even when you look at if the community is much affected, we can think of a diabetic, I'll call it groups or programs where they can meet and share different ideas and also
yes, I entirely agree. I entirely agree. Like some peer support groups.
Yes.
Yes, I entirely agree. Now, you're saying that if we have a defaulter vis-a-vis a newly diagnosed, we don't have that much discrepancy in initiation of treatment, honestly. If the patient falls under the category, you have done your fasting blood sugar, you have done your 2 or more readings, you have done your HbA1c, and you have all these other supporting information, family history, C-peptide, fasting lipid sugar, you initiate the patient on treatment. This session, however, will not take you through the deep, in-depth pharmacology. What you'll find in the notes and what I will assess you about, like we did for hypertension, is you need to know we have sulfonylureas, also called secretagogues, because their responsibility is to stimulate the beta cell through the sulfonylurea receptor to produce insulin. Sulfonylureas are first and second generation. Then you'll find binguanides where we have metformin. You'll find alpha glucosidase inhibitors where we have acarbose. You'll find thiolinidiones or glitazones where we have rosiglitazone, palglitazone, and the likes. You'll find insulin where we said under insulin you can have the rapid short acting or ultra short acting, the short acting, intermediate acting, and long acting. You'll find you have, which other ones have I prescribed? Yes, there's this very good, what is it? Sodium glucose transporter inhibitors, SGLT inhibitors. And in particular, they inhibit the sodium glucose transporter 2 in the kidney. So the famous drug there is dapagliflozin. So you find dapagliflozin, canagliflozin, mopagliflozin, etc. And then there are these GLP-1 analogs where we have things like exenatide. Then you have DPP-4 inhibitors where you have linagliptin, sitagliptin, etc. Most of these drugs are available on the market. I am going through them very fast because they're in the notes. When you get to the notes, please read them. You will be assessed, but you can't be assessed on prescription. That is not what we are looking at. In fact, you'll be assessed on a lot of prevention, levels of prevention, primary, secondary, tertiary, primordial. How would you apply the knowledge you have studied about diabetes mellitus in prevention? That kind of stuff is what you'll be assessed on. Diagnosis, you will be assessed because you can only prevent what you have made a diagnosis of. So if you went into a community and screened 200 people, to make a decision like Derek is telling us, whether you should initiate an NCD clinic in that community or not, you will need to have made a diagnosis, have a cutoff value, and said that out of the 200 we screened for diabetes mellitus, 150 of them had a fasting blood sugar of greater than 7 millimoles, meaning that you understand that the 7 per se is a very important marker, upper limit marker for the decision to make a diagnosis of diabetes mellitus.
So mine is a question.
Yes, please.
Yeah, I would love to inquire diabetic ketoacidosis as a complication. Is it only a cross-cutting complication in both form 1 of diabetes or form 2, or is just only more specific in other forms of diabetes only, but not general?
Sorry, I was off a bit. Robert, the answer I can give is the best way to approach this would be to understand the biochemistry of this particular disease, diabetes mellitus. If you look at, let me quickly take that direction. I hope I'll be helpful enough. If you look at DM type 1, we have no insulin being produced. So the patient is entirely relying on fat and protein. Later on, they initially start with protein, then the process is shunted to utilization of fat. So if you have no glucose being produced at all, we are entirely breaking down fat to produce energy. Therefore, we shall have a lot of the ketone bodies being produced, which increases the incidence of ketoacidosis in this particular patient. However, if you look at DM type 2, we have some glucose being produced. Therefore, the body does not entirely depend on the fat for energy production. And the hormone at the center of all this, the occurrence or absence of ketoacidosis in a patient with diabetes mellitus is glucagon. So if the insulin is low, glucagon is supposed to stimulate production of the stored conversion of the stored glycogen into glucose. The other thing glucagon does is that it stimulates the hormone sensitive lipase. The hormone sensitive lipase, no, glucagon inhibits the hormone sensitive lipase from coming into play. So the more functional those other, the beta cells, the delta and alpha cells are, the lesser the risk of developing ketoacidosis in the patient. So a DM type 2 has an extremely, low risk of developing ketoacidosis because they have some insulin being produced. And as a result, they do not entirely depend on fat for energy production. So if you are to ask me, the patients in my years of practice that I've seen with DKA, I have not yet come across a DM type 2. However, it is documented that in mixed pathologies, a DM type 2 can present with ketoacidosis. But classical, that is if you got a patient and they had maybe cosmos breathing, they had altered level of consciousness, they had that acetone breath, and they had the blood glucose of, let's say, 30 millimoles per liter, and then the deranged renal function test, and then on urinalysis, the heuristic shows you that the guy has ketones in urine, managed as DM type 1. Because in terms of pathophysiology, it would be very rare for a patient with DM type 2 to have ketoacidosis. I don't know if I've answered your question, Robert.
Yes, I've got it right.
So can we have a complication of hyperglycemia in type 2? Yes. But we have it independent of ketones in circulation. So usually we don't have hyperketonemia in a patient who has DM type 2 in complication. So the diagnosis will change from diabetic ketoacidosis to hyperglycemic because it is the first cutoff. It's the first condition. All these patients are in hyperglycemia. So the patient will have hyperglycemic, hyperosmolar, but non-ketotic syndrome. So this is the way you can differentiate hyperglycemia, complications of hyperglycemia and DM type 1 from those of hyperglycemia and DM type 2. One will have ketone bodies, another will not. Any other question? Please always remember how to approach prevention because we've looked at needs in terms of management, but someone can ask you, how can I prevent diabetes mellitus? Remember to organize your material: primordial, where there is no risk; primary, where there is risk, meaning a guy is obese, or is taking drugs, or he's not exercising, etc. Secondary, the guy has DM, but he's asymptomatic. The body is still compensating. So this is where, as a public health practitioner, you need to introduce screening services. Go into a community. And when I talk about community, we don't talk about a village. A community is a collection of people. So you can go to workplaces, these corporate workplaces, screen the guys for diabetes mellitus. For those who are found diabetic, if your facility can manage initiating the patients, initiate patients. If yours was mainly preventive, link the patients to NCD care for an NCD clinic. Jolly's workplace is there. You can talk to Jolly and they enroll the patients there. Then tertiary, we are managing, we are doing rehabilitation, preventing disability and death. So if it is a diabetic foot, you are managing aggressively so that the patient doesn't get amputated. If it's unfortunate and the patient has been amputated, can the patient get a prosthetic? Can the patient get a wheelchair? Can the patient undergo physiotherapy? Can they be able to operate to a certain extent and sustain a livelihood? That is what we are talking about in this particular case. Derek, is there any question? Does the group have any questions?
Someone was asking about DM, whether it can be a predisposing factor for polycystic ovarian syndrome.
Sorry, I was finishing up something here. So Derek, you're asking if DM can be a risk factor for polycystic ovarian syndrome?
Yeah, I've reposted the question in the chat as it was.
Yeah, but polycystic ovarian syndrome can be a risk for diabetes mellitus, not diabetes mellitus being a risk for polycystic ovarian syndrome. In fact, Derek and the class, one of the drugs that has proved to be more effective in inducing ovulation in a woman who has anovulatory cycles, like in this polycystic ovarian syndrome, is metformin. Studies have showed that metformin could actually be more effective than using clomiphene citrate. So yes, polycystic ovarian syndrome can be a risk factor for diabetes mellitus, not the other way around. Gestational, what does the person need on gestational diabetes mellitus? Because the content I uploaded has the pathophysiology mainly. Procy, is that okay? I think, I don't know who, no, it's not Procy. Who asked the question, Derek?
It was me up here. I've understood your explanation. It's very clear.
Okay, then, however, what I can do is maybe add a small, put in a small insertion on how polycystic ovarian syndrome increases the insulin resistance in particular, because that is what it does. It increases insulin resistance, and the type of DM it is inclined to is DM type 2. Any other questions? Okay, if there are none, please take off time. I'm going to enroll you later in the day. Please take time and read about childhood obesity and the obesity and childhood obesity, because the question came from there. That was, I think Kotias was asking about which type of DM would be seen in these patients, since obesity is mainly inclined to type 2 DM. So please read about that. And then in the catch-up sessions we are talking about, we shall talk about kidney disease, we shall talk about epilepsy, and then we shall switch and discuss and talk about cancer also. Then we shall talk about the risk factors, alcohol, we shall talk about cigarette smoking, we shall talk about genetics. These are very brief sessions, and we shall be good to go. I would encourage you to read the material on gender-based violence and synthesize the ideas on your own, and road traffic accidents, because this is really self-explanatory material. What is gender-based violence? How is it? What is domestic violence? What is intimate partner violence? What are the different types? What are the risk factors? What are the causes? How do we intervene as a public health practitioner, etc.? Are there any questions?
No, maybe the issue left is about the scheduling a lecture. Either
Yeah, you deal with you deal with the group, because for me I would prefer. You had told me that people prefer having a weekend. This weekend is Christmas. It would be unfair